years ahead of me. She came down to be the chair of medical oncology and has since become the director of our cancer center, Dr. Dronca. She's a medical oncologist at Mayo Clinic Jacksonville. She serves as a site director of the Mayo Clinic Comprehensive Cancer Center here in Florida and the director of Cancer Care Beyond Walls program. She has expertise, good shout out, includes treating advanced skin cancers, melanoma, as well as advanced GU cancers. She is involved in cancer research and education. Her work is motivated by her personal experience, including the loss of her daughter, Maya, to a brain tumor in 2021.
Thank you. Thank you very much. Now I'm going to have to find my composure here, but thank you very much to all of you for coming, and it's truly a pleasure for me to be here. I see so many familiar faces and friends here in the audience, and I hope that the symposium so far has been informative, and it's the first year, Dr. Jacob, and the team has put so much effort into the symposium, and I hope that we can see it grow over the years. But my task today was to discuss a little bit about the drugs, the systemic treatments. And initially, I think the talk was immunotherapy versus chemotherapy. I changed it just a little bit because we don't use a lot of chemotherapy in melanoma, and I can explain a little bit that, but we do use targeted therapy more, and we do use a lot of immunotherapeutic approaches. So these are my disclosures. So I just put the slide up here to kind of give us, orient ourselves as to what are the main, pillars of cancer treatment. Chemotherapy, as you see here, is one of our oldest, actually, treatment options for patients with cancer in general. And before we had immunotherapy and targeted therapy, it was an option for patients with melanoma and still is for individualized patients and situations. Radiation therapy is again, one of our oldest, options and pillars of treatment, and we still use this today for patients with both, stage 3 or earlier stage melanoma, as well as more for patients with stage 4 melanoma. Surgery, Dr. Jacob and his team, absolutely a big role in here. Targeted therapy is something that I will discuss about that has started more in melanoma in the last couple of decades, as well as immunotherapy. And you see here that while all the other treatment modalities work directly on the cancer cell, immunotherapy is a bit different because it doesn't directly attack the cancer cell, but it works through the immune system by making the immune system now attack or be better at attacking melanoma cells. This is kind of a slide showing the evolution of melanoma treatment in the last 2.5 decades or so. As I mentioned, chemotherapy was something that we had in the 1970s all the way to early 2000s, because there were not a lot of other options for patients with melanoma, and survival at that time for patients with stage 4 melanoma was poor because of the lack of many treatment options. And then right about when I finished my fellowship, we had this explosion of options, right? And we see how a lot of the targeted therapies here in blue have been developed, as well as immunotherapy options in orange above. And luckily, we continue to see options actually coming on, and a lot of research in melanoma and related skin cancers in the last few years. So we hope that we're going to have more drugs actually approved and on the market soon. And I'll talk about a couple of those. I put the classes of drugs here, although now with the newcomers, especially with the lifileucel, Amtagvi, and TIL therapy, this family will actually continue to grow. But kind of as two big classes, what we use now is immune checkpoint inhibitors or immunotherapy, as well as BRAF targeted therapy. And I'll kind of, talk about both and explain and dissect them a little bit as to how they work and in what situations. But these drugs, both immunotherapy and targeted therapy, as I mentioned, have revolutionized the ways we treat melanoma today. Back in, the 1970s, when we only had chemotherapy, as I mentioned, patients, did not have a lot of options. So the average survival actually of a patient with stage 4 melanoma was a year or so. Only about 12 to 15% of patients were alive at the 5-year, mark. And as we started using all these treatments, now with the combination therapies and more coming online, more than half the patients with advanced melanoma are alive and do very well long term. So we have seen definitely a significant change in the treatment of melanoma. So how this, title says, why is this superior? It's not superior. Why is it different? What are the differences between chemotherapy, targeted therapy, and immunotherapy? Just so we can kind of orient ourselves. And I mentioned one already, that chemotherapy, targeted therapy attacks the tumor cell directly, while the immunotherapy works through the immune system, so helps actually the immune system kill cancer cell. So for immunotherapy to work, it has to be able to activate the immune system, and the immune system has to be able to now kill the melanoma cells, which works in a lot of patients, unfortunately not in everybody, so we still need all the other treatment options. Chemotherapy and targeted therapy as well, because they work on the cancer cell directly, they only work while you give it to patients. So you have to keep giving it. You cannot, if you stop chemotherapy, or if you stop targeted therapy, for most patients, for a longer time, the cancer may come back. Immunotherapy, if that immune activation has happened, if the immune system finally got it, and now is ready to fight, the effects of immunotherapy activation may actually last a long time, even if you stop the immunotherapy. So we have many of you in the audience, and patients with melanoma who have been on immunotherapy have put the cancer into remission or in a very good place, and now we are able to stop that treatment and observe the effect continue. Different type of side effects. Chemotherapy and targeted therapy, because they, act on the cells directly, a lot of time will damage some of the normal cells that, maybe have a rapid or a more rapid multiplication rate. So these drugs then, think that that's a cancer cell because it's growing rapidly. And those are, cells lining our mouth, mucosa, cells in the bone marrow. So sometimes hair cells, so sometimes we see hair loss, we see some mouth sores, we see diarrhea, we see some vomiting with chemotherapy. A lot of times we see low immunity or infections, which is not as much the case with targeted therapy. On the other hand, with the immunotherapy, you don't have a lot of the side effects, but you have the effects of the immune therapy now maybe activating other parts of the immune system, or activating too much of that immune system that now starts to attack your own body as well as the cancer cells. So not being focused only on the enemy, but now starting to attack some of the other tissues, so causing what we call autoimmune side effects. So as I mentioned, immunotherapy works to stimulate your immune system to work harder or to work smarter. And some target a specific type of immune cells, such as the immune checkpoint inhibitors. So what do our T cells, or what we call them CD8 T cells or T cells, lymphocytes, need to fight the cancer? They need two things. They need first to be able to see that cancer, and then they need to be able to be activated to fight as well as multiply. So when a T cell needs to fight a cancer or to kill an enemy, as I mentioned, they need to see that enemy. So what we call in immunology is we have two signals to activate that immune cell. One is to recognize the cancer, and not all cancers can be recognized. Some cancers are not immunogenic or cold tumors, so the immune system cannot even go through this, or this first step doesn't even happen, which is a problem, because if you cannot see it, you cannot fight it. Melanoma is a more immunogenic cancer, and a lot of times, that's why the immunotherapy works, and these immune cells can be activated, but again, this is not happening in all the patients. And then to be able to activate or be stronger, we have a second signal that we call co-stimulation, so activating the immune cells. But the problem is that in the body, we have both positive signals activating the immune cells and negative signals, suppressing the immune cells. So the question is, why do we need negative signals? We need them in our body because we need to be able to turn off an immune response when we don't need it anymore. So if somebody has pneumonia or COVID or any other type of infection, your immune system gets activated, but then we have to have a mechanism to turn it off when we don't need it anymore. So the cancers have figured out that, okay, there is a mechanism that can be turned off, that we can turn off the immune response, so why don't we use it? So actually, a lot of the signals that the cancer cells use to turn off the immune system are these immune inhibitory receptors that are present on the surface of the T cells or immune cells. So there are a lot of switches on those immune cells, depending on what you want to do. You want to activate me, you turn this switch. You want to, suppress me, or you want me to not fight, you turn this switch. So the cancer has figured out what is what and what it needs to engage. So a couple of these immune checkpoints have become very relevant for treatment of cancers in general and for treatment of melanoma in particular. And a lot of this research actually started with melanoma. And I will mention a few names that you probably are already familiar with. PD-1, PD-L1, CTLA-4 are the very first three molecules that were actually initially discovered to be relevant in immunotherapy and fighting cancer. So normally, I'll show you a little kind of graphic here. So normally, our immune cells should be able to kill cancer cells. And probably this phenomenon happens in all of us. Many times when a cell becomes abnormal, the immune cell can recognize it and fight it. However, some tumors can block this interaction between the tumor cell and the immune cell and actually either kills the immune cell instead, or that immune cell becomes completely anergic, we call it, or unable to function. How is that done? Is through a protein that the tumors express on their surface called PD-L1 that engages with one of those receptors I told you about that turns off the immune system. So now you have the key in the lock and the immune system is turned off. So drugs that physically block this interaction prevent the cancer cell from killing the immune cells and reactivate this ability of our immune system to kill the tumor cell instead. So all you need is a block either at the PD-L1 level, at the PD-1 level, or other immune checkpoints. As we mentioned, CTLA-4 or LAG-3, I'll talk a little bit about that. But basically is blocking this ability of the cancer to engage the negative receptors. So the two first molecules that were described were PD-1 and CTLA-4, and both got a Nobel Prize actually for physiology or medicine a few years ago. But one of the one of the also important molecules that I talked about, PD-L1, the one that the tumor expresses on the surface, was actually discovered at Mayo Clinic. And I think few people know that, and we're hoping that Dr. Haidong Dong, who provided me with this slide from 1997, his lab book, hopefully he will get the Nobel Prize, one of these days, because truly it is all the three molecules, have played a significant role. This was a discovery around the same time when PD-1 and CTLA-4 were discovered. And he basically initially looked at this protein and they called it first B7H1. Nobody knew at that time what this protein was. And what he published initially in probably one of our most prestigious journal, Nature, he published that this protein, PD-L1, they discovered it and cloned it from the human placenta. And what he showed is that this protein PD-L1 forms a complete barrier at the placenta level between the mother immune system and the fetus. And the role of this PD-L1 is to prevent the immune system of the mom to attack the half foreign fetus, because the fetus is only half mom. So what the immune system wants to do, it gets rid of it, right? Because it's not us completely 100%, right? So this PD-L1 actually forms that barrier. When the immune cells come, it rejects them, so the fetus is protected. That was the very first discovery. And then a year later, the team discovered that cancer cells actually use this mechanism that they have hijacked from normal physiology to express this PD-L1 on their surface. So now we form a barrier, the cancer cells, so we cannot be attacked. So this publication, followed, it was in the in the late 1990s. I think this was in 1999, but it took until 2010 or 11 when the first drugs using these proteins actually started in clinical trials and became what we today know, the immune checkpoint inhibitors, Keytruda, Opdivo, and others. Now these immune checkpoint inhibitors are approved not only in melanoma, are approved in many different cancers, but the very first bigger trials were actually in melanoma. So I'll play a video from one of our patients from early days when Dr. Joseph, and maybe some of you remember Dr. Joseph was here, and we started using immune checkpoint inhibitors.
I felt 3 swollen areas in my neck. So first thing we did was go to a dermatologist, and he said, yes, they definitely need to come out, but I can't do it. He sent me to an ENT, and he said, yes, they need to come out, but if I take them out here, or if there's something they need additional attention, I can't help you. So he sent me to Mayo. I didn't actually know that it was stage 4 melanoma until we met with Dr. Joseph. And the first day that we met, he had to share the bad news with us. And I admire him so much just because of the way he did it. He didn't hesitate when he said everything shows that you have stage 4 melanoma, and there was not a pause or a silence. Immediately he said, but there's research going on that has been very effective, and the results are very promising, and I think that you possibly could qualify.
My name is Richard Joseph, and I'm a medical oncologist at Mayo Clinic, Florida, with a clinical and research interest in cancer immunotherapy. With immunotherapy, the patient is given a medication designed to make the body's own immune system recognize and destroy cancer cells. The key is coming up with a way to help the immune system recognize and attack cancer cells as it would with an infection. So we started him on a drug to take the brakes off the immune system. The tumors in his neck melted away within weeks. By the time we repeated his scan 12 weeks after starting therapy, his cancer was gone. He remains cancer-free 2 years after stopping all therapy.
He just gave us hugs and high fives, and he said, here's the pictures. Here they are. There's, it's gone.
Well, thanks to patients like Charles, who participate in clinical trials, we have now multiple new immunotherapies that are available, and they're providing patients hope for long-term remissions.
So all the drugs that are on the market today have started in clinical trials, right? All the breakthroughs have started in the labs, but then translated in clinical trials. So that's why it's important to always consider, options of new therapies. And that is a discussion between you and your physicians. But these drugs, all the breakthroughs in medicine have started in patients like Bridget and in patients, like Charles. This is one of my patients who actually in Rochester, while Dr. Joseph was doing this in Florida at the time I was in Rochester, like I said, just coming out of my fellowship, and Bridget presented with stage 4 melanoma, and actually she was given less than 3 months to live. She started on a clinical trial. We talked about these drugs. We said, we don't know a lot about them. These are new immunotherapy drugs, but it fulfilled what she wanted. She didn't want chemotherapy or any other aggressive measures, and she said, I'll try it. Very similar to, the patient that we presented. Actually, her cancer went into complete remission. And about 3 years after that, she discontinued therapy. Back in the day, those drugs were approved to be given to patients indefinitely. And then we noticed that a lot of patients went into complete response. So the question came, do we need to continue indefinitely when people are doing so well? And now the protocols are amended where we continue for a couple of years and then we reassess. So we don't do long-term treatments anymore if patients have a good response. I mentioned the side effects with immunotherapy, which are too much immune activation in your body. So inflammatory types of side effects when these immune cells get confused who they should attack. Is it the cancer? Wait a minute, now I recognize something that's, halfway familiar, and then they start to attack your own body. This happens with immunotherapy. If you use just one drug, severe enough side effects happen in less than 20% of patients or less than 1 in 5 patients. When we use a combination of drugs, two drugs or so, then the side effects can be anywhere between 30% and 50% of patients having this type of inflammation, depending on how strong the combination that we use is. As you see here, biology is not very exact. So I see a few of you in the room, and I know exactly that we talked about some side effects, and you had a side effect that was completely different from what we talked, because in a way, anything can happen. Just like people react differently, when COVID vaccine started and some people had reactions that were, unusual. When the immune system gets activated, everybody reacts a little bit differently. So while we have some more common side effects that we discussed at the time of the visit, sometimes, some more unique side effects can happen. The important thing with immunotherapy is that about 98% of the side effects are treatable and reversible. So it's important to recognize them early, to treat them with steroids, which is something that we do to calm down that inflammation. And most of them can actually be reversed. Switching gears a bit, because I'm coming up on time, to targeted therapy. As I mentioned, this is another major treatment options for patients with melanoma, and it targets 2 different genes. One is BRAF and one is MEK. The most important gene to have is the BRAF, and that's what we check for when we do a genetic analysis of the tumor to see if this is one of the treatment options that patients may have. The V600 mutation is the one that we check for, and it has different, the best responding is E, but now we're finding different letters, K and R, that may be responding as well to targeted therapy. We want to, despite, targeting the BRAF, we've learned, and this will be shown in the next slide too, that if we do an inhibition combined of the BRAF and the MEK, which are 2 different genes, if you use drugs that inhibit both, is actually stronger than if you use just one drug. And the different drugs that target BRAF are listed here, and the drugs that target MEK, are listed. And we use them in combination, and I'll show a slide on that. So how do these drugs work? BRAF is a gene in the body that tells the normal cells, when and how to multiply. But it's usually turned off in the normal cells when the cell is done multiplying. So in melanoma, that, turning off doesn't work. So this gene is like an overdrive. So these drugs really work by, inhibiting that gene. As you see here, this, is a pathway, complicated pathway in the, cell. And, when we target both the BRAF and the MEK, we inhibit this pathway even more so that, multiplication stops. These drugs work really fast, and they are more reliable in terms of, the response. 70% or, of patients actually may respond and may respond right away. So you need a response of the melanoma quickly because you have symptoms or issues, and you have this BRAF mutation is usually what we do if we need to control that melanoma, so we have time to switch to immunotherapy. There are some people who, and you see here, one of the PET scan here, a lot of, these, black dots are not supposed to be here. And you see that after using, the targeted therapy, you see a significant response. One of the issues with targeted therapy is that it works and it works well and fast, but sometimes the cancer will learn how to outsmart this drug, so may acquire resistance. So you want to use these targeted therapies when you need them. And then, some patients after immunotherapy, stay on these drugs and potentially can be actually on these drugs controlled for a long time. And again, I see some of you here that are controlled on these drugs for a long time. What we also know after a few studies were done, is that even if you have the BRAF mutation, it's actually better for us to try immunotherapy first. Because if immunotherapy works, we may have, a good outcome, and then we save those targeted therapies for later. If it doesn't work and we need to switch to targeted therapy, you want to still give the immunotherapy the best chance before you use other treatments in the body. We also don't know yet how to best combine immunotherapy and targeted therapy. There is one combination that is FDA approved, but it's a little bit more cumbersome, to use. So not a lot of oncologists use it. We would like to have, for instance, combinations with the drugs that we use today to be able to put them together. And some of that research is ongoing. But so far, we don't know exactly how to do them both, combine them for a better response. This is just a typical kind of, table that we oncologists use to look at, the response rate. CR means complete response, PR means partial response, and here PD means progressive disease. So you see here that the response rate, 76% of patients, respond anywhere between with a different combination, encorafenib and imetinib, dabrafenib, trametinib, or vemurafenib and cobimetinib. Among between 70 to 76% of patients treated respond. So that's a, great outcome. And the only issue is that the response doesn't stay for most patients, long-term, meaning long-term. Now we want in melanoma 5 years, 10 years, right? We want our patients to, be controlled for a long time. So this is still an area of research. How, do we, again, combine this with immunotherapy to prolong this response? They do have different type of toxicities than immunotherapies. And you see here, between 40 and 60%, 65% of patients may have that what we call grade 3 or 4 toxicities, means toxicities that we need to treat or intervene, or, that potentially need medications or hospitalization, etc. But the side effects are a little bit different than what we see with immunotherapy. Patients can get fatigue. They may have some, rash, dry skin, some cough or pulmonary inflammation, but I think some nausea or vomiting. I think some of them that are more, typical for this is fevers. A lot of patients, who are on targeted therapy may experience, especially in the first few months, some recurrent fevers, eye toxicity, some heart toxicity, as well as, joint pains, muscle pains. A lot of the side effects with targeted therapy actually become a lot less intense as the treatment goes on. So the first 2 to 3 months are very difficult. And a lot of times, I tell my patients, we need to get through this, whether we decrease the dose or we start and stop or we escalate slowly, because once your body gets, more used to this, the side effects will lessen. Some patients may have, just like with immunotherapy, some side effects that are serious enough, eye toxicity, problems with the heart, that we may need to stop therapy. But again, those are not as common. Most patients actually are able to take treatment. I put this here just kind of to show, when we see patients, with stage 4 melanoma, how do we go through that algorithm? How do we decide from all these drugs that we have, how do we decide what is going to be indicated for a particular patient? So we look at how much melanoma is there, and we kind of decide whether we can start just the one drug, that has lesser side effects, either, Opdivo or Yervoy, if there is not a lot of melanoma in the body, or if, let's say, somebody has a lot of other medical problems that if we have a side effect, could be very impactful on, their health. If somebody has a lot of melanoma, including in the brain and the liver, we know that we need to use the most powerful combination that we have, which is Yervoy and Opdivo. If somebody has an intermediate, there is more melanoma than just a couple spots, but not quite as much that we need to, pull out the big guns. What is here, anti-PD-1 and anti-LAG-3, is what we know as Opdualag, which is another combination treatment that we have in melanoma. And then targeted therapy is here if we have, like I said, a lot of melanoma that we need initially to calm down so we have time to get the immunotherapy we get started with the targeted therapy. We try to switch patients to immunotherapy after 2 to 3 months if we can, but sometimes we cannot, so we have to get back to targeted therapy. Sometimes we are able to now successfully control the cancer, and again, we keep the targeted therapy for later if we need it. So this looks really simple, but it's not. There are a million other, and I just put this as an example, there are a million other steps, and that is why every single patient, the treatment is individualized for themselves. We have to take into consideration a lot of other different variables, including one's, fitness level, medical comorbidities, goals, what exactly do we need to do as the next step, et cetera. And we come up with what is the best for you right now. And then in my mind is, okay, and what is plan B, C, D, E, because I need to have them line up so to make sure, that patients will have options for a long time. So other immunotherapy options, I'm not going to spend a lot of time on this because Dr. Jacob, had a great, talk and a lot of information for you, I think, before lunch. But tumor infiltrating lymphocyte therapy is really a powerful option that now we have for treatment of melanoma. I'm going to touch upon oncolytic viral therapy, which are viruses that are designed and genetically engineered to just infect tumor cells and leave the normal cells, unaffected. Why do we need these viruses? Because as I mentioned to you, in order to fight the cancer, you need to see the cancer. Some tumors, including melanoma, which is an immunogenic tumor, but in some patients, these tumors, what you see here, they are cold. Cold means they don't have immune cells in them. If there are no immune cells in them, we can give the immune checkpoint inhibitors all we want. There is nobody to activate. There is nobody home. The hot tumors are the ones that have a lot of T cells in them. They are just not able to fight because they have that inhibition that I mentioned. All they need is that immune checkpoint, to restore that. So hot tumors are easy to treat. Cold tumors, not as much. So these oncolytic viruses actually, when you inject them in the tumor, create so much inflammation in the tumor that in some tumors turns them from cold to hot. Because now they disrupt, a lot of the cells there. So now there's going to be an infiltration of the immune cells coming in there to see what's happening. Why is the commotion here? And bringing those immune cells into the tumor is what we need to then use the immune checkpoint inhibitors. So this is what it shows here, that the oncolytic viruses in general, they leave the healthy cells undamaged. But when they go into the tumor cells, they start multiplying. There is so much virus in there that now those tumors will burst, and then they will create more viruses that will infect the nearby cells, but then they will also create an inflammation in that tumor. So TVEC is our first immuno-oncolytic viral therapy that was approved, for melanoma. It is a genetically engineered herpes virus. And when I say this, everybody's like, wait a minute, maybe not for me. But it is actually a virus that doesn't, infect, like I said, normal cells, doesn't create herpes, but it's a herpes virus that now it's not designed to be non-infectious, but be designed to just infect the tumor cells. And it has a couple of immune, genes inserted in them, so to enhance that inflammation inside the tumor. This is an example of, TVEC. Where these viruses work best, or at least TVEC, where it works best, is injecting lesions, especially with what we call in melanoma, in transit melanoma or locoregional melanoma, where you can see these lesions popping up. And it's very hard for Dr. Jacob to keep taking them out. Then doing, these injections in that area will create so much inflammation there that will control, some of these tumors. So this is an option that we use a lot for in transit. Some patients with melanoma of the scalp benefit from this, but it's not, powerful enough to inject it, for instance, in the leg, at least right now, and create response in the lung for somebody, for instance, if they have more, advanced disease. But there is a new drug coming, and we hope that this will be, kind of a second generation oncolytic virus that we can still use TVEC for where we need, local regional but this RP1 virus is similarly a herpes, genetically modified herpes virus that is designed again to infect the tumor cells. But what this one has a little bit, additionally, is that it creates responses in some of the non-injected lesions. So it is used in combination with Opdivo, with one of the immune checkpoint inhibitors. And as you see here from a study that was ongoing, IGNITE clinical trial presented at our last oncology meeting last June. This patient had the lesion injected, here in the forehead, and a lot of these lesions that were still present in the liver and the lung, which were not injected, responded as well. Okay, so this about 30% of patients who have progressed on immune checkpoint inhibitors, when this trial was conducted and this RP1 was added, 30% of patients responded, which is a significant number considering that in patients who already have been through immunotherapies, melanoma is harder to treat. So we hope that this will be yet another treatment options in the future. And actually the FDA approval is expected sometime this summer if it's given. This drug has already a breakthrough designation with the FDA, and I think the FDA review is expected to be at the end of July. So like I said, more and more options are coming down the pipeline. Very important not only to talk about treatments, and that's why you have Dr. Musalem. I think talking a little bit later is to take care of yourself with nutrition, with exercise, with taking care of your body, and focus on all the other aspects and not only the cancer. So I have 2 minutes now for questions. Dr. Jacob, I'm still on time.
If a patient does not have BRAF or wild type mutations, but does have NRAS and STK11 and TERT mutations, you still recommend the same type of treatment?
No, the treatment, the targeted therapy is specifically for BRAF. The other ones do not respond. BRAF is what we call a driver mutation, meaning this mutation is something that is promoting the cancer, to grow. So when you stop it, it can reverse the cancer. A lot of the other mutations may be present because the cancer is very unstable genetically. It grows so fast that it doesn't even know what it wants to do. So some of these genes don't even have time to properly, multiply. So the cancer is very unstable, and some of these mutations are there, but not all of them are relevant for the cancer growth, or we have good drugs to inhibit that. So for the mutations you have mentioned, we don't have yet good drugs to be as effective as the BRAF, drugs against the BRAF mutation. Yes, sir.
So just 30 seconds of background. I met Dr. Dronca last August with stage 4C melanoma pretty much everywhere except the brain. Learned a lot about all this stuff in a really short period of time. Went through it, and then amazingly by December 10th, the scans were pretty much clean. So just want to say not only to Dr. Dronca, but everyone at Mayo, and as I learn about the Melanoma Research Foundation, thanks, because I wouldn't actually be here without all that stuff. But I do have a question. So as I can, I want to try to pay this forward because it was such a life-changing event. What are the best ways for anybody to support and advocate for research? Because gosh, since December, yeah, I saw that. But since December 10th, and I started my journey, you've got TIL being FDA approved. You had the subcutaneous delivery of what I received, which is just easier treatment. So, it's amazing how quickly everything's happening. But if that research doesn't continue, like you said, don't want to turn into a political conversation, but how does an individual, best help support the efforts other than writing a check, which is obviously an important part of it
Yeah.
too.
I think it's, and I'll let you, speak as well. I think it is very important because actually nationwide, less than 10% of patients participate in clinical research. So it's a very low number. It should be, 30, 40, 50%. All the patients should have the option, to participate at some point on a trial. And there are many barriers. One is, not everybody lives around an academic center. Not everybody has the means to come, a lot. Sometimes patients, don't really know it. So empowering people to, know where to look up and, to discuss with their doctors is important. Getting involved, through melanoma advocacy groups, where there are groups out there and, blogs and people who are newly diagnosed, they look for support and they look for information. And a lot of that information is actually from their peers who've gone, through this. At Mayo, we also have a program that is called the Citizen Scientist Program. And that's actually, patients going through some training about clinical research in such a way that they later on become advisors to the researchers, which is also important. Sometimes we develop our research and our studies and we're like, in our lane. I know this is needed. And, having the patient voice and be like, wait a minute, but have you considered this? And from a patient perspective, this is important. It helps come up with a better research. So we actually use a lot of our patients from, the Citizen Scientist Program to be advisors and part of our research team. So I'll let you also.
Yeah, it's so fascinating because, as Dr. Jacob was saying, research takes such a long time. I mean, looking back at those dates and seeing how long it took to get TIL to the market. Well, when I was at Johns Hopkins, they were talking about viral oncolytics, and they actually stopped doing it because it was killing patients. And now there's one FDA-approved treatment and more coming down the pike. So research is so vitally important. I would say, to answer your question, the biggest way that we can make a difference right now with all of the potential cuts to research, and again, the federal government is the largest funder of research. Pharma will never make up the gap that we currently have. So to give you a little frame of reference, melanoma research gets $40 million a year through the Department of Defense. And why it comes through the Department of Defense is because our servicemen and women are exposed to very high rates of UV radiation, and their diagnosis rate of melanoma almost doubles the civilian population at a certain point. So the DoD has heavily invested in that. We go to Capitol Hill every single year with our advocates to tell them why this funding is so critically important, because every year it goes back down to zero. So we have to tell them why we want this funding. So we got the $40 million again for FY25. There is the potential for this entire program to be cut in FY26. We were one of a very few cancer programs that remained in FY25. Many other disease line items were cut completely. Pancreatic was cut completely. Lung was cut completely. Prostate was reduced. Breast was reduced. So it is so important. And I know it kind of feels like my voice doesn't make a difference. It really does with your lawmakers. You are their constituents. You are, the ones that are contributing to their tax base. And so we host an event every year in March in Washington, D.C. We provide patient scholarships. So if it's, challenging for you financially to get there, we do have scholarships available. And we do a 2-day training where we train you on the issues, we educate you on the issues, and then we set up meetings with your lawmakers. So you'll meet with your representatives on both the House and Senate side, and you'll be able to tell them your story, why you're still here and why a clinical trial saved your life and why it's so important that we need them to sign on to, the appropriations bills, why we need them to voice their concern about the cuts to NCI and NIH. We heard about the trials that happened there until, many, many years before it was commercialized. So it's vitally important that you use your voice and you talk to your lawmakers. And we can also help facilitate meetings in your own district, in your state. So if there are, again, if you're passionate, we will work with you. We will help set up those meetings. We will help you with their talking points. But the biggest thing is just sharing your story and why it's important. And then we will give you all the information on the actual ask. But it really does make a huge difference. We've seen it over the years. And again, I'm happy to talk with anyone who'd be interested in learning more about being an advocate and coming to Washington, D.C. in March.
Thank you very much.
We got people on. We got virtual.
Oh, I'm sorry. So, what Kylie said is so important. And I have to be somebody who looks at the government and says, why are we funding all these things? And I'm learning a lot today. And I appreciate Kylie and Dr. Jacob and Dr. Jacob for expressing that to us. And your story is incredible and super happy that you're here with us today. My story is much simpler in the fact that I had 5 melanomas. It led me to, like you say, what can we do to make a difference, right? And so I started getting Naked Jacks here in Jacksonville because I didn't feel like I could make a difference in the science, but I knew I could raise money. And so we talk about writing checks, and is that important? My goal with what we do here is 3 things: is to raise money for cancer research, number 1, not to a general bucket that just goes to overhead and other things. Our goal is to really fund money directly to grants, and we've been fortunate enough to fund 4 grants, or 3 grants. I'm sorry, 4. Anyway, she knows all the information. I run the show. And so it's gone very well. The second goal is to raise awareness for skin checks. I mean, that's plain and simple. My story is that I went to a dermatologist for years, got tired of going paying $50 for 30 seconds, and I just thought it was a waste of time. My wife thankfully made me an appointment after finding her first issue, and we found 2 melanomas day 1, and I thank her for that. And so that's number 2. And then number 3 is to make what we're doing here in Jax not about me. Because it's about the people in this room, right? All I'm doing is facilitating, helping you guys fund cancer research. And so as we move forward, attrition lies within my sphere, I call it, of people that are sponsoring the events. And so we need help from people in this room that live here in Jacksonville, that have a story, that have a passion, that want to continue the charge. And so that's kind of what I challenge everybody with. Certainly your mission, and I didn't know about the thing in March, and I've been involved with this for 5 years, and that may be my next step and step away from this. But I think everybody, we're hearing incredible things. We're seeing the research at work. Dr. Jacob said it so elegantly at our last statement that, we're working these men and women out of a job, which is great, right? Hey, that's what we're here to do. And so we've got to continue to lead the charge, and it can't end with us walking out of this room, because all of us will walk out of this room, we'll move on with our lives, we'll forget about our goals. And so we've got to continue that process. So that's kind of just a small answer to your question. Her answer was much better. I've just kind of given you what our approach is locally. So thank you. Yes.
Yeah. So MRF is obviously national. Jason's work has been grassroots, local, all contributing to the same big picture. And it's been really exciting seeing the dollars actually, like you said, fund specific projects. I haven't been political, I think, at all, but the people who we elect, we vote for. So I think they want to hear what your preferences are of what we do with our money, your money. And then if someone really has a big check to write, we have a benefactors wall, and Mayo does accept big checks with a very specific focus. I want money to go to this, and this is important to me. We won't turn your way.
I think you're right. If you are passionate about this, you can raise funds. I raise funds for pediatric cancer. I don't know how to do it. I just, started gathering a bunch of doctors and I make them dance. So we have, and Dr. Jacob was one of my dancing doctors last year and placed second, should have been first because he had an amazing performance, raised a lot of money for pediatric cancer. So.
Got a couple, I'm going to do the online questions. Is Dr. Muslim here? Okay, yep, got a couple, perfect. If you have I'm just going to read them. These are people online. If you have a rare, severe side effect to immunotherapy after one treatment, in this case, attacks your pancreas, and your cancer goes into remission from such an extreme response, what are the treatment options if the cancer returns?
That is a great question. And this actually happens. In some patients, you give one dose and the response is so powerful that we cannot give more, or sometimes we don't even need to give more for a while because also the cancer goes into remission. Now, it all depends. If the side effect was to a combination of the 2 drugs, a lot of times if the cancer returns, we can use just one drug. A lot of times the combination, and if it's, for instance, with the Yervoy is that, little nasty drug that does it, but then we can just do, Opdivo alone, and patients can actually be treated successfully. If the side effect was with one drug, then it's a little bit more difficult, especially if it was a very severe side effect. If it was severe, not very severe, sometimes we tentatively, can try. But fortunately nowadays we have other options, right? We have Amtagvi or the TIL therapy. We potentially have, this oncolytic viral therapy. If patients have BRAF mutation, we have BRAF mutation, and then we have clinical trials. So we still have options, despite that reaction.
I understand BRAF is less common in acromelanoma, making targeted therapy less effective. But why is immunotherapy less effective in acrolentiginous melanoma, and which immunotherapy drugs are more effective?
If I knew that, I'd probably have, I don't know, my name on a wall someplace. It's true. Acral melanoma, which is melanoma of the, toes and fingers, by the nails, is a little bit more stubborn than the regular melanomas. Doesn't have a BRAF mutation. Sometimes has a mutation, what is called KIT. And we have drugs out there that inhibit the KIT mutation, but they don't work as well as the BRAF drugs. So it is an option, but it's not a fantastic option. In general, acral melanomas do not respond as well to immunotherapy, and that's kind of a known phenomenon in the field. So we try to use the combination of two drugs. Hopefully now, with the Amtagvi, potentially, that we'll see more response in acral melanomas. We already are seeing that TIL therapy actually can have a response in mucosal melanomas, which is another rare subtype of melanoma that starts inside the body actually. And those in the past had no response to other treatments, and TIL therapy seems to have a better